Hello everyone, welcome to our final section on blood bank antibody detection and identification. And then we're going to go into some details on some other blood bank topics, and then you'll be done with blood bank and we'll move on to the next chapter. All right, so we've been through the process thus far of doing the ABO-RH. So we're going to find out the patient's blood type. We've done the antibody screen. Antibody screen is negative, we're going to go into finding compatible blood. If antibody screen is positive, we're going to perform an antibody identification. And once we identify the antibody, then we're going to find compatible blood. So the goal of antibody screen and antibody identification process is to find compatible blood for the patient. That is our purpose. This is where everything that you learn now comes together. Okay, so we're going to put the whole system together. And I think that once you understand the process of what we're doing, some of the concepts of MNS, leave the rest, all those things that we talk about will probably start to make a lot more sense to you. So we talked earlier on about phenotype frequency. How often does a particular antigen occur within a population of patients? We also talked about the fact that certain races have a higher frequency of certain antigens than other races. So what we can do is use the phenotype frequency to find out how many units of compatible blood might be available for a patient who has certain antibodies. For instance, how many units are compatible with a patient who has an anti-JKA? So this means we got to find people who are negative, who do not have the anti-JKA. If 77% of the population are JKA positive, that means 77% of them will not have the antibody. So 7.7 out of 10, right? Because you translate it. So we can find out that, hey, if I screen 10 units of blood, I should be able to find compatible units for a patient who has JKA. The question then becomes, well, how many units do you need and how many other antibodies they have? So we'll get into figuring that out. Okay, so you cannot make an antibody to something that you have. So if you are JKA positive, you're not going to make an anti-JKA. So that means 33%, well, 23% of the population is going to make an anti-JKA. So you got to find blood for that 23%. So what is combined phenotype calculations? That's how we can estimate the number of units that we have to test in order to find a certain number of antigen negative units. If a doctor orders 2 units of blood on the patient and the patient has an anti-JKA, we need to find out how many units will we test to find 2 units that are negative for JKA. So in this case, if I test 10, if I know 7.7 out of 10 units will be JKA positive, then that means I'm only going to find 2.3 units, right? So only 2.3 units will be compatible. So if I cross-match 10 units or antigen type 10 units, I might find 2 units that are JKA negative and therefore compatible with the patient. So let me explain that to you with some words behind it that you can visualize. Here's an example. There's a patient. The patient has an anti-C, an anti-Kel, an anti-JKA. How many units must be tested to find 4 of the appropriate phenotype? So you need to find 4 units of blood, which are all anti-C negative, anti-Kel negative, anti-JKA negative. What you have here is the frequency of negative units within the population. So with C, 20% of the patient population will be negative for little c. That means 2 out of 10 people will be negative. Kel, 91% of the patients are negative for Kel. That means 9 out of 10 will be negative, right? And JKA, 23% of the populations will be negative. We're just going to say 2 out of 10 will be negative. So then out of 10 units, 2 units should be negative for little c. Out of 10 units, 9 should be negative for Cal. And out of 10 units, 2 should be negative for JKA. The question is, how many of those units will be negative for all 3 at one time? So let's erase this. So what do you do to find out? Well, multiply the individual phenotypes to get the combined phenotype. So we took 20%, changed that 20% into a decimal, which was 0.2 out of 0.2 out of 100, 91%, which is 0.91, and 23%, which is 0.23. You multiply all of these together and you come up with 0.04, which means 4% of individuals will be little c, Kel, and JKA negative. 4% means 4 out of 100. Remember, percentage adds up to 100. So therefore, you will have to test 100 units in order to find 4 compatible units of blood. Does that make sense? Now, of course, in the real world, laboratory world, the regular hospital, we don't do this. We actually call our blood center who has already done the screening and say, hey, I need 4 units that are negative for little c, Kel, and JKA. But we have to first identify that little c, Kel, and JKA are present. If you're in a reference laboratory, you will be doing this. So let's discuss Hardy-Weinberg Law. Yes, you may have a question about Hardy-Weinberg Law. You may only have one question. Notice there's going to be a couple of things you have to remember. One, it is math. It is a mathematical formula to explain the persistence of recessive alleles in a population. It's based on assumptions. Population must be large. Mating must occur at random. Mutations must not occur. There must be no migration, differential fertility, or mortality of the genotype. Equation for a 2-allele system, which most of our antigens are 2-allele systems. P2 means P squared plus 2PQ plus Q squared equals 1. So what this means is whatever alleles you have, if it's, let's just say it's JKA, that's JKA and JKB. So let's just assume that here JKA is going to be P squared and JKB is going to be, I'm sorry, not P squared, but P. Let me erase that. Get my eraser to work. JKB is going to be Q. So those are the individual alleles. What this says that when I take JKA and I square it, and then I add it to 2 times P plus Q, and I take Q and I square it, it's going to be equal to 1. In essence, the squares kind of just canceled themselves out here, and so P plus Q equals 1. So it's like 2 halves make a whole. So it's going to always add up to 1. So here's an example. What I was just saying. Kid blood group system, JKA and JKB. P is the frequency of JKA. Q is the frequency of JKB. P squared is the frequency of JKA times JKA genotype. And we know some people are JKA positive. 2PQ is frequency of JKA-JKB phenotype. Okay, so which one of these is homozygous and which one of these is heterozygous? If you guess this is homozygous, you are correct because it's JKA and JKA. If you guess this one is heterozygous, You are correct because it's JKA and JKB. Hetero means different, homo means same. Okay? Remember Homo sapien, one species, man species. And the final one, Q squared, is the frequency of JKB genotype. So this is saying how often this particular genotype occurs within the population of people, how often this particular genotype occurs within the population of people, and how often the third frequency of genotypes are found in the population of people. Which, if you notice, these are the only combinations you could have. You could only have JKA plus JKA or JKB plus JKB, and then JKA and JKB together. So let's put some numbers to this. We started off by saying 77% of the population expresses the JK antigen. That's the first thing. So that means they're JKA positive. If we use the equation, P squared plus 2P squared equals the frequency of persons who are JKA positive, right? That's because we said P squared represents JKA, JKA, and then we said 2P squared represents a person being JKA and JKB. All of these people, if you just put a plus sign here, meaning they are positive for JKA, the first one JKA, JKA, the second one JKA, JKB. Okay, so these individuals, which this was the P squared, and this one was the 2PQ. So they all carry the JKA allele. So now if you take the equation and you say Q squared, which is what you do not know, these are the frequency of people who are JKA negative. That means they have to be JKB positive, JKB positive. This is what you're trying to find out. How many of these people exist? That was represented by Q squared. Okay? So now the original equation was P2 plus 2PQ plus Q squared, that's what the 2 is, equal 1. If we use math, we have to take and move everything over to the right-hand side of the equation. In order to do that, you subtract what's on the left-hand side minus the right-hand side, and you get Q squared equals 1 minus P2 plus 2PQ. In this case, 77% of the population is 0.77. Q squared is 1 minus 0.77, meaning 0.23. And then Q is equal to square root of 0.23. Q is now equal to 0.48. That's the frequency of JKB. Now this is going to call for you to think about some basic algebra skills. If you don't know basic algebra, we could talk about that because I also tutor in math. So we could go through some math in another section. And when you get into chemistry, there's a ton of math that we're going to go through. A lot of math problems if you haven't already taken chemistry. Okay, so here we have Q is going to be 0.48 allele frequency. All right, so 0.48, okay? 0.77 is how many? 77%. 0.48 is 48%. Okay, so 48% of the people have a JKB frequency. So let's take this out further. One, we already said that the sum of the frequencies have to equal 1. So P plus Q is 1. P is 1 minus Q. P equals 1 minus 0.48. So P equals 0.52. The frequency of JKA is 0.52, just because you have to subtract 0.48, 1 minus 0.48. Okay, so that's how often the JKA occurs. Number of JKB persons can be calculated. 2PQ plus Q squared is frequency of JKB. Why is that? Because 2PQ means that includes people who are JKA positive and JKB positive, and then Q squared is going to include the people who are JKB positive. So in order to come up with the total number of JKB positive, you have to include both sets. You can't just say, oh, Q squared is JKB. No, you can't forget about this portion. And that's why I see students mess up with these calculations. They forget about this 2PQ section because they see it has JKA in it. But remember, it has JKA and JKB. So in this case, now we're going to take the 2 equals 0.52. We get the 0.52 over here. P equals 0.52. You see this? P equals 0.52. So that's for JKA. All we've done is taken the P and out of the equation and substituted 0.52 for the P, because that's what we said P was. And then where every place where we have Q, we put in 0.48. We determined that on a previous slide. So if we take, and when you have parentheses, remember that whenever you have a mathematical equation, you do what's inside the parentheses first. So you do the calculation inside this parentheses first. And the thing about this is that if you don't, you can get the wrong answer. And a lot of tests will have the wrong answer on it just to see if you did the math correctly. And I know it seems like it's not fair. I've had students say, well, that's not fair, and why? And I would have gotten it right. Because in our world, we don't have the option to get it wrong. Okay? We have to get it right the first time. So if you take and you do what's in the parentheses first, 2, so that means you would take the 0.52 and you multiply it by 0.48. You can do this at home and you're going to get 0.2496. Okay? That's one side. On the other side, you have to get 0.48 squared, and then you're going to take the 0.2496, multiply that times 2, and multiply that, and add the 0.2304 from the 0.48 squared to get 0.73. Okay, so you're going to have to commit that Heide-Weinberg equation into memory, because unfortunately some things just have to be memorized. The next portion of this presentation that we have to deal with for special tests. So part of the challenge that, we have goals for everything, and part of the goals for blipping when it comes to the boards is that the student must be able to demonstrate knowledge of tests to detect and identify autoantibodies, antibodies to self, and alloantibodies, foreign antibodies, and methods to eliminate or diminish cold reactions in vitro, which means vivo is in the body, vitro is in the tube. Address cold agglutinous, auto, and allergenic antibodies that cause ABO discrepancies. So now we're going to talk about some tests that can help you achieve that goal of knowing how to demonstrate knowledge of how to get rid of cold antibodies or eliminate the reactions, and how to identify the auto and allo antibodies. One technique you can use is called pre-warming. I mentioned it briefly in a previous presentation that you had. The technique in which red blood cells in serum or plasma are pre-warmed separately to 37 degrees before they are combined. So that's what you're doing. You take and separate your red blood cells and your serum, put them in two separate tubes. Then you warm them up in an incubator, a heat block, at 37 degrees, most of the time for 15 minutes. And after you've warmed them up, you combine them together. What this does is any cold antibody normally disappears because the cold antibodies like the 4 degrees Celsius. They like it cold. So now when you warm them up, they don't come together. So then you get rid of them. And now you can see what else is there, because normally the cold antibodies are not significant. So we use this when autoantibodies are present that can mask clinically significant antibodies, but you have to be careful, because when you do this, sometimes you can get rid of a weak antibody that you were trying to pick up on. And you don't want to do that. So it's best to run the antibody screen first, and after you have gotten your results, go back and do a pre-warm. That's normally what we do. This is a schematic of what it looks like. Now, notice in this schematic, it says you do it for 10 minutes. That's going to be something that's based on wherever you work, right? But 10 minutes, 15 minutes, okay, both of those are technically correct. Follow the incubation, transfer serum to cells, and continue incubating for 30 minutes. This is extended time. So we talked, many presentations ago about reducing zeta potential, allow antigens and antibodies to come together, and ways by which we could do that. Those ways include longer times of being around each other. Let the antigens be around the antibodies and give them an opportunity to stick together. And if they don't stick together after this extended time, then they're probably not going to be clinically significant. Next thing we do is we wash 3 times with saline and add anti-human globulin. So there's something that you're going to see on another slide, and it's going to come up later. Do not warm anti-IgG reagent. Avoid warming saline used for washes. Now I can tell you, when I started, they used to tell us, oh, warm the saline, warm the saline. They've since discovered that you miss antibodies when you do that. So we don't do that. The other thing is adding list or peg is not recommended, because then peg kind of clumps it. It has this weird thing that it does. It kind of gels, and then you get false positives. So you got to be careful. The best thing is to always follow the manufacturer's recommendation. Other thing to remember is that despite the time, when you're taking a test, just pay attention to the fact that you have to warm the serum separately from the cells, and then you have to incubate them together, and then you have to add some kind of enhancement reagent, wash them with saline and all that. You got to do these other steps. But the time you might not be 100% on when you take the test, but you have to know what the procedure is. It's called pre-warming, because before you do the test, you warm up the cells in the serum. Okay, the next thing we're going to deal with is warm autoantibodies. Warm autoantibodies are really what you see in the blood bank. They're more common than cold autoantibodies. Warm autoimmune hemolytic anemia can be idiopathic or the result of disease or drug. This becomes important because before we talked about, you have to get the patient history. You can have a drug-induced warm autoantibodies. Now, are warm autoantibodies the most common antibodies in the laboratory? No. Warm allo antibodies are the most common. Allo, other, foreign. Those are the most common antibodies that you see in the laboratory. Most panel cells in autocontrol will be positive when you have a warm autoantibody. You can use 22% albumin to decrease reactivity, noting that when you use the albumin, you do have to incubate longer than you would if you use LIS. The reason you have warm antibody testing is so that you can determine if underlying alloantibodies exist, because those are the ones that are going to cause the transfusion reaction. The warm autoantibody is something the patient has to themselves, right? Once we identify it, we need to make sure we give them blood that's negative for it, but we don't want to miss something else. And the warm autoantibody normally causes us not to be able to see that clearly. All right, so warm antibodies mainly from the Rh system, the little e antigen, and that's really where I've seen it the most. Patients will have an anti-little e antibody and the e antigen, and they'll have a positive direct Coombs, direct antiglobulin test. You can give them E negative blood to increase red blood cell survival in chronic hemolytic situation. But remember, little e is a high frequency antigen, so it's very hard to find little e negative blood. It can be done. It's just difficult. Medications can also cause formation of warm autoantibodies. Again, patient history is important. So here is something that you might want to just kind of glance over and know something about drugs and drugs that cause a patient to have a positive DAT. So drug independent, mechanism unknown, autoimmune process resolves itself when a drug is discontinued. This means that the patient will have a positive DAT until the drug is no longer being taken. Now this, of course, is based on half-life. Drugs stay in the body for a certain period of time. So you have to make sure the drug has been out of the system for whatever time the half-life is of the drug. Here are some drugs here. Methodopa, fludarabine, and then over here, this one's drug-dependent non-immune protein absorption. Causes modification of the red cell membrane, demonstration by antibodies that react in the presence of the drug. Cephalosporin, which is a common drug. Cephalotetan, cephalotrexazone, non-steroidal anti-inflammatory drugs. Those are NSAIDs. You can get those over the counters. So when a person has been taking too many of those, guess what? They can actually have a positive DAT. Here's some drugs that they react by binding the red blood cell membrane. They attach to the red blood cell membrane, causes red blood cell clearance by macrophages, which you'll discover later is very important in the immune system. Okay, so then you have penicillin, cephalotetran. So these are some drugs that can be rather common that could give a person a false positive, meaning you would think they would have a warm autoantibody, but it really is a drug-induced autoantibody. All right, more things you have to know. Demonstrate knowledge of tests to elute antibodies from red blood cells. So when we have a warm or cold autoantibody, we have to find a way to get rid of it, right? This is what you're going to learn next. Demonstrate knowledge of immune destruction of red blood cells by hemolysis and extravascular processes. Elution. Elution is a technique where we use to remove or disassociate the IgG antibodies from sensitized red blood cells. So when a person has a positive DAT or direct antiglobulin test or direct Coombs, it all means the same thing. The immunoglobulin G, IgG, in essence, think warm antibody, must be removed from the patient's cells. And then you can find out what else is below. The recovered antibody is called an eluent. The eluent is used in antibody panel. So now the eluent is used just like we would use serum. We would test it and see if we get any positive reactions, and this will help us see what that first autoantibody was covering up. Okay, so when do we do elutions? Normally in the laboratory, you do it with hemolytic disease of the fetus and newborn. Normally it's an ABO-RH discrepancy. And then it may not be reactive in all cases of warm autoantibodies. We'll talk about hemolytic disease of the fetus and newborn more. It has its own little section that we'll go through that. That's coming up soon. You should probably get into that next week, as a matter of fact. If you're doing the self-paced version of it, this hemolytic disease of the fetus and newborn should be coming up after this antibody identification, actually 2 sections after this one. All right, so elution methods, how do we do it? There's different ones. There's temperature variations that can be done, which means you go from warm to cold and cold to warm. pH manipulation, acid elution, we do that most of the time. So that means you make the environment really acidic in order to cause the decrease in pH, and then the antigen-antibody bond is going to separate, and now that antibody is going into the acid solution, which is the eluate. Okay? And then you add buffer at the end to raise the pH back up to an alkaline state. And when you do that, you can now test that eluate. And then we have chemical, which means you're going to take a chemical and add it to the mixture and it cause the same thing to happen. Here's a table that shows you elution methods. Glycine acid lowers the pH. Heat freeze thaw is a physical one. Ether methylene chloride, chloroform, is an organic solvent. The last one is not used as much because it's very hazardous. Notice it's carcinogenic. Glycine acid is the one we use most often. And heat freeze thaw, we used to use that all the time for ABO-RH. It's a quick way to find out if a person has a blood type issue going on with hemolytic disease of the fetus and newborn. Not sensitive for antibodies other than ABO-RH. That's why a lot of people do acid elution, because they can pick up on other antibodies. All right, another technique that we can do when a person has an antibody, a warm autoantibody, we have what's called adsorption, ADSORPTION, adsorption. Remove antibody from serum. So the patient's serum is incubated with red blood cells under whatever temperature the antibody needs. So if it's a warm antibody, then it can be 37 degrees. If it's a cold, it can be 4 degrees. The warm autoantibodies may need to be removed to test for underlying alloantibodies. That's why we do it. Cells can be pre-treated with a certain enzyme, DTT. Remember we talked about this with KEL, or a combination of enzymes, ZZAP, and that combination is going to remove the attached antibodies. Chloroquine diphosphate is another thing. EDTA is another thing which we use in our purple top tubes. Ethylene diamine tetraacetic acid. That's EDTA. All right, continuing on. Once you do the absorption, the patient's serum is incubated with the red blood cells under what? 37 degrees for warm, 4 degrees for cold. You need to remember that. You should remember that anyway from all the antibodies that we've talked about. Cold antibodies, 4 degrees. Warm antibodies, 37 degrees. IgM antibodies are normally cold antibodies. IgG antibodies are normally warm antibodies. Here's what autoabsorption looks like. Take the patient's serum, treat with something, EDTA, DTT, ZAP, to remove the autoantibodies. Add the patient's serum to the treated cells and incubate for 30 to 60 minutes. And notice this is a long procedure. And I can tell you I've done this, and you sometimes have to do this 3 or 4 times before you get all the antibody off. And it is very time consuming. Remove the serum and test for alloantibody. Okay? So that's the first time. And sometimes, like I said, it doesn't work. Differential allergenic absorption. In separate tubes, incubate the patient's serum with 3 different phenotype red blood cells. You do this when you think the person has more than one antibody. Then you remove serum and test each separately with panel cells to determine specificity. Very time consuming, takes a lot of specimen. You have to have the patient redrawn for it. So if you notice here, the cells used for absorption, KEL positive, JKA positive, and then Duffy A and B negative. Next one, KEL negative, JKB positive, Duffy B negative, little s positive. The third one, KEL negative, Duffy B positive. So if I get reactions in cell number 1, but I do not get reactions in cell number 2 and 3, that's KEL positive in number 1. So I would think, oh, KEL was on the cell causing the issue. That's pretty much what you do. It can be very time consuming. the key is for you to know what the procedure is and the basic steps of doing it, and what you do, why you do it. So problems with resorption is limited by the transfusion history and amount of sample. And if a person has been transfused within the previous 3 months, you can't do it because you're going to pick up the red blood cells from the previous 3 months. Remember, red blood cells survive for 120 days. So if a red blood cell survives for 120 days, you're picking up what you transfuse to that person most of the time. So severely anemic patients may not have enough red blood cells to carry out the procedure. So people with low hemoglobins can't do this on. Okay, and cells are usually treated with enzyme to remove bound alloabsorption. Cells phenotypically like those of a patient are used. Enzyme treatment removes some antigens to aid in matching and enhances antibody up. So here's some problems. Phenotype from red blood cells coated with immunoglobulin can be a challenge. If we treat it with chloroquine diphosphate, it can disassociate, take away the immunoglobulins from the red blood cells without harming the antigens. Here are some things that you can use for absorption techniques. Now I want you to remember these because if you had a test and it asked you which one of the following tests is used for absorption of warm alloantibodies, then you have to be able to recognize that REST, rabbit erythrocyte stroma, is a technique used to remove cold IgM antibodies, particularly anti-I. And then cold autoabsorption is going to patient cells are used to remove cold autoantibody warm autoabsorption, and there's a reagent called warm. That's what the name of it is. Patient red cells are used to remove warm autoantibodies, and differential allogeneic adsorption. Known phenotype cells to separate specificities, separate the warm from allos. So you kind of just need to know this from a reference of a simple table of what it does. This is kind of like a good little cheat sheet. Rabbit, remove cold antibodies. Cold autoabsorption, remove cold autoantibodies. Warm, remove warm autoantibodies. Differential, we're going to have phenotype red cells. We briefly mentioned this technique called neutralization, where we talk about Lewis. So neutralization uses soluble antigen to inhibit the reactivity of certain antibodies. So you should have a positive reaction before you neutralize the antibody. Once you neutralize the antibody, you should have a negative reaction. So soluble antigen is added to the patient's serum, mixed in incubated room temperature to neutralize, and then the neutralized serum is tested against panel cells. You have to have a saline control. The saline control is going to be reactive because you have not neutralized it. Okay. So what can we neutralize? Anti-P1, you can have hyded cis fluid. That's normally what you see. And so that's why I associate that with P1. Anti-Lewis, we can have regular plasma or serum to neutralize it. Cheeto-Rogers, regular plasma or serum. And SID is urine. And here are the most common ones I see. I see a question about SID. I see a question about Lewis. And then sometimes we see the hyded cis fluid question. But these other two, those are your most common ones. So this is going to be the end of this presentation. Don't worry, we have more to come. So review this. I'm going to also post some other videos for you to help you understand some of these techniques a little bit better. And we will go from there. I will see you in the next presentation. Thank you. Remember to send me your questions. If you don't understand something, please send me your questions and I can answer your questions. It can become better for you. Thank you.